She is going to tell us in 10 minutes on disorders of pupil, which is going to be very challenging, but I am sure she'll bring out all the take-home points for the postgraduates. On to you, Dr. Shikha.
Good evening, everyone, and thank you, Dr. Chitra, for this opportunity. Pupillary disorders include all this, but I'm going to cover the important points which I felt were important given in the red box. Now, the normal pupils are described by the acronym PERLA, which means pupils equal, round, and reactive to light in accommodation. Usually 2 to 4 millimeters in diameter in bright light, and in dark 4 to 8 millimeters. Now the iris dilator muscles are present radially and are under sympathetic control and cause dilatation benign. Whereas sphincter muscles are present circumferentially and are under parasympathetic control, lead to constriction of pupil. This parasympathetic control comes under the pupillary reflex. Let's see what happens. When we shine light in the left eye, the temporal fibers from the retina reach in the pretectal nucleus on the ipsilateral side, and the nasal fibers reach the pretectal nucleus on the contralateral side. Now the ipsilateral pretectal nucleus goes and stimulates both the Edinger-Westphal nuclei, and so does the pretectal nucleus from the contralateral side. So what is important is that when shining light, both the Edinger-Westphal nuclei are getting stimulated equally. Now, the third nerve starting from the nuclei, going to the ciliary ganglion on the same side, and then through the short ciliary nerves reach the sphincter pupillae and constrict the pupil equally on both the sides. So you're shining light in one eye and both the pupils are equally reacting to light. The same thing happens when we shine light in the other eye. Now the relevant sympathetic pathway anatomy. Here the first order neurons are starting from the brain, and that's in the posterior hypothalamus. From there, it goes to the ciliospinal center of Butch, that is at the level of C8 and T2. From there, the second order neuron reaches the superior cervical ganglion, and from superior cervical ganglion, the third order neuron starts and it goes inside the brain along the internal carotid artery and reaches the dilator pupillae muscle. Now, coming to the pupillary evaluation, we should look at the shape, size, and the reactions, pupillary reactions, which include direct and consensual reaction, relative afferent pupillary defect, and near reflex. Why do we do this? To look at the ocular and general health of the patient. These shape-related issues are actually related to the iris structural defects, as we'll see in the next slide. And size-related issues usually tell us more about the efferent pathway defects, and relative afferent pupillary defect tells us about the problem with the afferent pathway, that is optic nerve related defects. Now, these are self-explanatory shape disorders of the pupil. Out of this, I would like to tell you something about the aniridia. It is an autosomal dominant condition due to a defect in PAC6 gene. And if there is no family history of aniridia and a child is born with aniridia, it's prudent to do the surveillance for Wilms tumor, which could be seen in these patients till the age of 8 years. Now, let's come to the pupillary disorders of the size. Anisocoria refers to a difference in the pupil size of more than 0.4 millimeter between the two eyes. If it increases in dark and the patient has ptosis in the eye with the small pupil, you're looking at Horner syndrome. If it increases in bright light and the patient has ptosis and motility abnormality in the eye with the larger pupil, you're looking at third nerve palsy. And if there is no ptosis and no motility abnormality, probably the patient has AD syndrome. It could also be a physiological anisocoria, that is, if it remains the same in dark and light, but it's usually less than 1 millimeter. Now, unilaterally dilated pupil can also be seen in traumatic mydriasis, in rubeosis, and if you have put some dilating drop. Similarly, unilaterally miotic pupil could be a physiologically small pupil, or could be seen in uveitis or because of the pharmacological constriction. Adystonic pupil is typically a unilateral midriatic pupil, commonly seen in women, and it's because of the denervation of postganglionic supply to the sphincter pupillae and the ciliary muscle, which usually follow a viral illness. What happens when we shine light on AD's pupil? We see vermiform movements of the pupillary border because of the segmental contraction of the iris sphincter. The near reflex is usually normal, but the redilatation after the near response is slow. And over a period of time, the AD's pupil becomes miotic when it's called little old AD. And when we have diminished deep tendon reflexes along with AD's pupil, it's called Holmes AD syndrome. And if there are disturbances of sweat secretion, it's called Ross syndrome. How do we confirm the diagnosis? Since we said there is denervation supersensitivity, which is elicited by putting dilute 0.125% pilocarpine. Because of the supersensitivity, the AD's pupil constricts and the normal pupil does not. There's no particular treatment for this condition. The accommodative response improves over a period of time. It's important to reassure the patient. Now, coming to the Horner syndrome, we've seen the anatomy of the sympathetic pathway. If there is any lesion along the oculosympathetic pathway, the patient can have meiosis, ptosis, and hydrosis. The signs can be really subtle. The partial ptosis is because of the paralysis of Muller's muscle, and in the near and light reactions, there can be a dilatation lag, and there's an apparent inophthalmos because of the slight elevation of the inferior eyelid as a result of weakness of inferior tarsal muscle. Anhidrosis is seen only in the lesions below the superior cervical ganglion. Now, how do you confirm the diagnosis of Horner syndrome? You can use 4% or 10% cocaine eye drops, which block the reuptake of the norepinephrine released at the neuromuscular junction, and the normal pupil dilates, whereas the Horner's pupil does not dilate. If you don't have cocaine, you can use 1% apraclonidine. It's a weak alpha-1 agonist. We've seen the denervation supersensitivity in ADs. Similarly, here there is a denervation supersensitivity because of which the Horner's pupil dilates and the other pupil does not, normal pupil does not dilate. How do you localize the lesion? You can use 1% hydroxyamphetamine eye drops. They act by releasing norepinephrine at the presynaptic terminal. So if the postganglionic neuron is dead, then obviously it will not dilate. Hence, if the pupil is dilating, then you can localize the lesion to the first or second order neuron. Now, dissection of internal carotid artery can be a devastating condition and can present as Horner syndrome, especially painful Horner syndrome. Let's look at this case, a 46-year-old male who came with burning sensation on the right side of the face with some vague complaints of decrease in vision. He actually didn't have any decrease in vision. What he had was an anisocoria of 2 millimeters. As you can see, the anisocoria was more prominent in dim illumination. The ptosis was very subtle, around 2 millimeters. And on the basis of these findings, a diagnosis of Horner syndrome was made. Patient was sent for MRI with MRA of the head, neck, and chest. And we found the dissection of the distal cervical internal carotid artery. Patient was sent to the interventional radiologist, started on oral antiplatelet agents, and a stroke was averted. Now, if an adult presents with the same features, that is ptosis, meiosis, and hypochromic heterochromia and is asymptomatic, then you have to ask for older photographs and look for the ptosis and meiosis, which has been there since early childhood. In such a case, you don't have to order very elaborate investigations for Horner's because you could be seeing a case of congenital Horner's. Now, people involving third nerve palsy could be harboring important lesions like a PCOM aneurysm, and neuroimaging is a must. It can also present as multiple cranial nerve palsies. That is, pupil involving third nerve palsy can have a fourth, fifth, sixth, as seen in this case with herpes zoster ophthalmicus, and the lesion localizes to sphenocavernos area. You can also have pupil involvement in a sixth nerve palsy. Usually, it is a constriction of the pupil that is seen because of the associated Horner syndrome with sixth nerve palsy. Here we had a case where the pupil was dilated, but nonetheless the lesion localized to the same place, that is in the cavernous sinus. Now, this is my last slide. We should know how to elicit the relative afferent pupillary defect. We will go back to the initial anatomy slide where we saw that when we shine light in one eye, both the third nerve nuclei are equally getting stimulated, hence both the pupils constrict. So if the whole pathway is working properly, that is, optic nerve is a part of that pathway. So if it is working properly, both the pupils should constrict. Now here, the left eye is normal, right eye has got optic nerve lesion. We shine light in the left eye, both the pupils are constricting. We shine light on the right eye where there is a defect, both the pupils are dilating. This dilatation is what is happening is there is no constriction occurring here, but the dilatation is because of the withdrawal of this stimulus. So what is happening is this is a swinging flashlight test which is done to diagnose relative apparent pupillary defect, and the eye with the optic nerve damage, that pupil dilates. So there are a lot of points in pupillary disorder which are from the exam point of view important, but I haven't covered. You should go through all these. All the best.
Thank you. Thank you very, very much. That was a wonderful talk, Shikha. Really enjoyed it. So I'll ask one question before Jyoti takes on.